there a way? Alrighty, can everybody see this? Good. Hello, my name is Katyln Baker, and myself and Brooke Gall, we are both brain injury physical therapists at The Ohio State University, and we work in outpatient rehab at our Martha Morehouse location in Columbus, Ohio. So tonight, what we're going to be talking about specifically are different therapeutic interventions for spasticity management. And so what we really wanted to also ensure we got through with this presentation is how we're not saying how do we get rid of spasticity, how do we abolish it, right? It's how do we live with it and how do we manage it? If you tuned in last week with Dr. Vivishi's presentation on learning like what is spasticity, where does it come from, why do I have it? I think it's a really good one. If you haven't watched it, I would go back to it. But again, this is just like what's the reality of living with it? How do we manage it? And how do we function and live our best lives with it? And how can we as PTs, OTs help you with that? So we have no financial disclosures. And then by the end of this presentation, we hope that you as listeners will be able, again, to just define and understand what spasticity is, understand what therapeutic treatment options are available in order to manage the spasticity you might be going through, and then confidently seek out the appropriate interventions or resources for spasticity management in a clinic near you. So we're very fortunate to have everything that we're talking about today. But what we want you guys to know is like, what are the tools? If I'm unable to make it to Columbus, Ohio, where am I at? Do I need to search out at a clinic near me? And can I see, oh, I haven't tried this type of intervention before. I wonder if they have this type of modality. This is a list of things that you can take to these therapists and say, do you think this will help me?
So let's start with a review from last week on what spasticity is. So spasticity is a motor disorder characterized by velocity-dependent increase in tonic stretch reflexes. So if we break that down, it's a movement problem that is defined by a speed-dependent increase in stiffness in your joints. And that comes from impaired signals from the brain. In brain injury, this could start right away, or it could start at any point after your injury. So up to 50% of individuals at some point in their after their injury, they will develop or spasticity. So what does spasticity look like? It can present as hypertonicity, which means increased tone or stiffness. It would feel stiff. It could be clonus. Instead of a stiff muscle, it would be kind of like a rapid movement off and on two different muscles on each side of the joint. It could feel like general stiffness. You can't move your arm or your leg or a limb as far as you could maybe before your injury or at any point in your recovery. It can feel like reduced range of motion. Maybe it's not stiff, but it won't move as far. It could be spastic dystonia, which is posturing of a limb, hyperreflexia, where you move quickly after a triggering stimulus. It could feel like muscle spasms like you might have had before your injury. It can cause scissoring, so one limb would cross over the center of your body, or it could look like a clasp knife phenomenon where it's a tight grip. Spasticity isn't always bad, and that's important to know. Sometimes it can be a problem, and there's certain situations where if it gets to be too bad, you want to reach out to therapy. Well, how do I know if my tone's starting a long time after a rehab even? When should I maybe seek more PT to figure out what I need to do to get my function back? So if you're having pain or what you describe as discomfort, if it feels stiff or you can't move as far as you could before, if a leg or arm is posturing in a way that you can't control, if you've lost dexterity, which is fine movement of your fingers or your hand, if you're having a hard time getting dressed or performing your daily hygiene routine, if you're noticing that you're having contractures, which is where you're unable to move the joint or the limb at all, If your functional mobility becomes limited, such as walking, standing, transfers, or even moving around in bed, if you're having more loss of balance because of the spasticity, if you're having uncontrolled fluctuations in tone and you need to be able to manage that better because it's affecting what you can do throughout the day, and if you're at an increased risk of heterotopic ossification, which is bone growth in your muscles where it shouldn't be because of the neuro problem. So some of these issues you would want to seek physical therapy, and in some of these issues you'd want to seek occupational therapy. In our clinic at OSU, we tend to split upper and lower body. So if you're having problems with upper body posturing or dexterity, getting dressed, or doing what we call ADLs, activities of daily living, which would involve your hygiene tasks, occupational therapy would be able to work with you on those things and teach you management strategies. Whereas physical therapy tends to focus more on the effect of spasticity on loss of balance, on functional mobility, like I was saying, with transfers, bed mobility, walking, and also teaching stretches of the lower limb and trunk. So like I was saying, spasticity is not always a bad thing. It can benefit your body and or how you move. So the contraction from the muscle spasm can help maintain the bulk of your muscle where you would otherwise see muscle wasting or atrophy. The muscle starts to get smaller from disuse. It also provides a muscle pumping effect where it can help get blood back up to your heart. It can help you prevent blood clots through that muscle pumping effect. And it can also prevent osteoporosis by helping build or maintain bone through the muscle contraction from spasticity. It can help you prevent pressure ulcers. And like I said, it can help prevent with functional mobility. So under the spasticity is a lot of muscle weakness, but you can use the spasms or the stiffness to help you stabilize, such as doing a stand pivot transfer or a swing through transfer, where you can get that extensor straight leg tone to help get weight through your legs and stabilize you while you're performing some mobility.
And we have some stuff in the chat. Grace, are there any other questions that you have that you would want to talk about before we move on? Or did I answer that question for you?
You answered it. Thank you.
Okay, you're welcome. So we'll go ahead. So now that we've kind of reviewed what is spasticity, what can it look like? Is it bad? Is it helping me? Now we want to go into the different interventions for managing it. So what can we as rehab do to truly help? So again, what we're going to be discussing, these different type of modalities and rehab management strategies. Again, it might work for you, it might not, it depends. Unfortunately, like a lot of research in brain injury, there's not a lot. But the good thing is like all of these interventions have been supported and they've been cleared for use within the brain injury population. It just depends if it will work for you or not. So a lot of times we trial a lot of these different things, and it might be you do a combo of some of these different interventions. So we're going to talk about all of those on these next few slides. So we're going to talk about each of these separately, but what can we do in our clinics to help you? So we'll look at different ways that we can provide a continuous muscle stretch, whether that be trialing different positions, different stretchings stretches that we can teach you to perform, as well as teach your caregiver to perform. Because a lot of times with stretching, it's something that you need to do every day for the rest of your life. And it just has to become part of your daily routine. We can also look at different splinting options that are available and sometimes different casting options. We also have different modalities such as functional electrical stimulation and neuromuscular electrical stimulation, which we'll talk more about. Different activity-based therapies, including locomotor training, as well as different weight bearing and standing frame options that are available. You can look at doing things in the pool, different aquatic exercises. Sometimes the warm water can help relax you, relax your muscles. So sometimes just being in a warm water pool can be really good for spasticity management, as well as dry needling. So we have a question mark there on purpose, promise it's not a typo. But dry needling it's new. It's not new in the sense with rehab, but it's new in spasticity management. So I don't know if anybody's ever heard of it, but they're these little tiny needles, and their goal is to target the muscle tissue and specifically different trigger points or tightness in the muscle to help restore your function. Unfortunately, there's not a lot of data in general, whether it be a neurologic condition, whether it be an orthopedic condition. There's just a lot of subjective, which means patient reported outcomes. I can say myself personally, and I'm sure Brooke has a few patients, we've used it in the clinic and we've had some good subjective reports where they feel looser. So again, it's up and coming, which is exciting because it's another modality and it just allows you to get deeper with that needle compared to using hands or other stretching. So be on the lookout for that and see if there is a clinic near you that possibly would have it. So these are some different standing frames that allow you to get.
Caitlin, can I just jump in real quick?
Absolutely.
So dry needling and acupuncture, same thing or different?
So they're different. Brooke had a really good way. How did you describe it the other day? Like, so the
from
dry.
what I know of acupuncture, where they put the needles is based on like ancient Chinese, I forget what they call them. There's certain zones of your body, like your third eye is one of them. So they use those strategies for where they would put the needles versus we would place them where the muscle is spastic or in muscles that are spastic
Right.
instead of the systemic effect.
Yeah. So like, yeah, the acupuncture would be more of that systemic effect, like she was saying with the dry needling. So for example, I have a patient in their calf. They're really, really tight down by their Achilles tendon and then their lower calf. And so they have trouble clearing their foot when they're walking because they can't get dorsiflexion and their toes are pointed. So another therapist that's certified in dry needling, he has been needling their Achilles tendon as well as their lower part of the calf to release some of that tension. And then in combination with other stretching and splints that we'll talk about later, that we've been able to gain more motion in her ankle, which has allowed her to clear her foot better. Does that make sense?
It's not as common to have neuro-specific PTs have their dry needling certification. It's not something that you learn in PT school. It's something that you have to become certified in after PT school. And you get certified in specific parts of the body, the trunk, the arms, the neck, the legs. Because there wasn't a lot of research out up to now, neuro PTs weren't focusing on that as a modality for spasticity, but it's something that you may see up and coming. It's just don't expect to see it commonly in rehab facilities that you may be seeking out.
Yeah. And it is, I do like, I feel like people are more familiar with acupuncture, right? Like with the little needle. So that's what we do compare it to. Just the, I guess the thought behind it is just slightly different.
Yeah, I think that makes sense. And thanks for that explanation. And I'm just curious then, so if it's not acupuncture, you're promoting dry needling, would you then suggest acupuncture as another tactic? Or is that something that you're, again, data and things like that are lacking? But
no, I would say it's, again, one of those, there's not a lot out there. I think Dr. Bavishi actually does do acupuncture though. So I know that it has worked. I've had other patients that have done it and utilized it. So it is one of those that I say, try it. It's not going to hurt you, right?
Mm-hmm. And dry needling, just like acupuncture, a lot of insurance companies aren't paying for it because there's not a lot of research that backs it up. So you'd have to figure out at the clinic that you're seeking it out, how much that might be out of pocket to see, just like acupuncture, is it worth trialing for you? How many times are you willing to try that and pay out of pocket for it? And is that number of times going to give you, the best bang for your buck and what you're looking for long term?
Yeah.
all right, thank you.
Awesome. Great conversation and question. So different types of ways that we can get a continuous muscle stretch. So different types of positioning and weight bearing is very important for spasticity management. So one is standing, and the best way to do that, if you can't do that on your own, right? If we're sitting a lot, if we're not as mobile as we used to be, standing frames are the perfect invention. These three at the bottom are different examples that we have in the clinic and that we've also helped patients get through the use of waiver, or some insurances will cover it. But with the standing frame, right, the goal is that we're upright. We're getting really good extension in our leg muscles and our trunk muscles from instead of sitting, right? If we're in a wheelchair most of the time now, if we're just, again, not up and walking as much and we're in this sitting shorted position where our legs are bent, a lot of times that's where we can get the tighter muscles. So the standing frame on the left, if you see, it has a little sling bottom. So if somebody has really good core and trunk strength and they're able to keep themselves upright, this is a really good option because you're able to challenge your core a little more and you don't need as much external support compared to the middle standing frame, where you can see it has the head, mid back, and like bottom support as well. So it's sturdier, it gives more support for you if you do need that. So that's another option. Both of them have, you have spots for your feet to fit in, and then a knee joint, like a knee block. So it blocks your knees into extension and holds you there. And then they have tray tables too. And then the one on the far right is a glider. So it is a standing frame, but you're able to move the arms and then your legs are gliding in a forwards, backwards motion. So it gets you to be a little more active while you're up and standing. And it's really good for cardiovascular training. If you're unable to like go be on a treadmill or get on a recumbent bike or something, this is another option. Not only will you get the benefits of standing that we'll talk about in the next slide, but it's really good for the cardiovascular system as well. Other positions can be just lying prone, which is lying face down on your stomach. Again, if we're sitting all day, our hip flexors can get really, really tight, as well as just our trunk. And so if we lie flat, we're able to stretch out those hip flexors, stretch out our legs, and improve that overall extension. So what are the benefits of positioning and weight bearing, and specifically standing? Now, you're able to improve and then, of course, maintain range of motion. Our goal is, of course, to decrease any type of joint or muscle contractures that we talked about earlier, manage atrophy of our trunk and leg muscles, improve the strength. So there's different ways that we can strengthen in these standing devices. Just weight bearing alone can help decrease our muscle spasms that we might be experiencing. It promotes proper muscle and skeletal development. It improves and maintains our bone integrity. It manages pressure because if we go from sitting to now we're standing, we're relieving some of that pressure on our glutes that we might have, and trying to reduce any risk of skin breakdown. It can also help improve bowel function and regularity. It can aid in bladder function and then strengthen the cardiovascular system and help build endurance, as well as improve circulation.
Another way to get a continuous muscle stretch is through stretching. So the important thing to know to get a continuous muscle stretch is that it needs to be held for a long time. The best type of stretch is a low load, so a light stretch where you're feeling it, but it's not uncomfortable or painful, and for a long time. As Katyln was saying previously, the way that you get benefit from stretching is by performing it regularly. So that means 2 to 3 times a day, every day of the week, 30 to 120 minutes a day, if you're breaking that up. So if you're going to physical therapy 2 or 3 times a week, even 4 or 5 times a week, that's once a day where you would be getting stretching. To gain benefit, you have to do that several times throughout the day, including on your own. So how does stretching help you? It helps prevent the loss of sarcomeres. So a sarcomere is in your muscle, and it's a piece of your muscle that causes the contraction. And so if you lose a sarcomere, that part of your muscle, you could lose part of your typical contraction. So it prevents loss of that ability. It reduces buildup of connective tissue. Skin is a type of connective tissue, for example, and it minimizes changes in length, tension relationships. So your muscles work best when they are at a certain length. That's when you would have the biggest force output and you would feel the strongest. So if your muscle is so tight that you have an alteration or a difference in your length tension relationship, you won't be able to use your muscles to the maximum capacity that you want to or need to. And like we were saying before, stretching can also reduce muscle atrophy, which is the muscle wasting or less muscle. So pictured here are different types of splints that can provide you a continuous muscle stretch. Splints hold you in a position for as long as you have it on, but it's not on permanently. So you have the ability to remove it and put it on, or have a caregiver remove it and take it off. Usually your therapist, your occupational, if it's upper body splinting, or physical therapist, if it's lower body splinting, will give you a wear schedule of how often you should have it on, how often you should take it off, and then how to care for your skin underneath it. So there's resting hand splints and resting ankle splints. That first picture on the top left would be examples of resting hand splints. And the one on the right would be a resting splint for your ankle. That one is actually, if you were to search for it on Amazon, it is a plantar fasciitis night splint. So it was not intended for spasticity, but it's something both Katyln and I will recommend to patients because it's $30 on Amazon. You don't have to go through your insurance to get payment for a very expensive medical piece of equipment. It's something that you could attain with Amazon these days in 2 days. So that's something that you could wear at night on your ankles to prevent your ankles from kind of naturally over time starting to bend down, which would make your calf muscle tight. There's also something called Lennard boots. You'll see those in inpatient therapy a lot of the times. That's pictured on the bottom right, that fuzzy gray looking one. There's something called Benic anti-spasticity splints. That would be those pictures of the hands you see kind of bottom left. And then we can also try kinesio tape to your fingers or your toes, those are your digits. It's not as strong of a hold, but it is, again, like we've been saying, something that we can trial depending on how strong your spasticity is. It may be enough to where you wouldn't need a full-on splint. Dynasplint is a company that us therapists at OSU work closely with. It's a type of splint that provides a static stretch that also progresses. So it works through pulleys that will hold your hand in a certain position and also provide further stretching into the direction that you're hoping to gain range into. Okay, so the last form of continuous muscle stretching that we use is called serial casting. So this is pictured on the right. As you can see, it looks just like a cast you might get if you were to fracture or break your arm or leg, built from similar materials. There's a couple differences. The angle of the one on the very left, you can see, is a little bit wider back. And then as the cast is updated, it's brought more into a neutral right angle, angle. So that's what you would need for standing and walking without having various impairments up the chain because of having to walk with an ankle that's not in neutral or stand with an ankle that's not in a neutral 0-degree right angle position. So the cast would be made in your therapy session, and then that's updated every 1 to 3 weeks, depending on how much stretch we're getting out of it. Every time you come into therapy, we would assess, okay, how is your skin responding to it? How is your range of motion, or how much you can move your joint responding to it? And we can gradually improve that range over time instead of keeping it in one position for a long time like a splint would. There are certain situations where a cast wouldn't be appropriate. If you have poor skin integrity, meaning there's a high risk of skin breakdown underneath there, you're wearing it for 1 to 2 weeks at a time. So it's staying on and not coming off the way a splint would. So if your skin were to break down under there, that could cause more problems than you would gain benefit out of the cast. If you have hypertension or increased in intracranial pressure, or uncontrolled autonomic storming, those are situations where it wouldn't be appropriate because those are other medical emergencies that you would want to handle at that time, and wait until you're in a bit more stable of a position to have something like a cast on that isn't removed. If you have a recent fracture at the site that's going to be casted, or if there's a lot of swelling there, that wouldn't be appropriate for serial casting. If you need to be able to access that limb to deliver medications, or access for like to get an IV in there, or to check vital signs, you don't want that area to be blocked off, because again, it's not like a splint, it stays on there. And then if you have bony limitations or some kind of protrusion that would prevent the cast from being safely applied, if there would be too much pressure in one spot, then that would not be appropriate, because it could cause more damage than it would do good to you.
Any questions on anything that we talked about from the continuous muscle stretch? I know we've had some conversation in the chat, but anything else? So like Brooke was saying too, a lot of times after Botox, the serial casting is a great time to take advantage, because now your muscles are getting looser, and then we're able to get that long, prolonged, continuous stretch to really try to see some really good changes. So that's where we work in conjunction with people like Dr. Bavishi to figure out what's the best thing we need. Erica, do you have a question?
Yeah, I do.
Oh, I think you're muted again.
Sorry. Is spasticity the same as tremors? Pretty much, right?
So it can present
Right.
that way. Yeah.
Okay, so my question, I don't know if you're going to touch base on that today or not. So I'm a survivor, a traumatic brain injury survivor, and I am 8.5 years past like my initial accident day. And for this hand, I have tremors really bad in this hand, but only if I'm going to get close to my head, or like typing on a computer. But other than that, they're fine.
Yeah, so that would be, and correct me if I'm wrong, Brooke, more of that like intentional tremor, where like I'm intentionally trying to do something with my leg, and then I just start to shake and I can't control it. So that would be, so we do have patients that come in, and we try different types of, which we're actually going to get to next, the STEM, to see if different types of functional electrical stimulation can almost tire that tremor, and see if we can try to control it better that way. Sometimes it's different, like what Dr. Bavishi might have talked about last week, like different medication uses. It's a little combo of both. So it depends, but it is something that we do assess in therapy and can try, like, see if any of our interventions can help. So that would be, especially if your tremors have gotten worse, Erica, I would like reach out, and especially if it was never addressed prior, because that's something, right, that's impacting your ability.
Right. I'll just say they are a lot better than where they used to be, how bad they used to be. Like I can never hold a cup or anything. But I used to be on medications for that, but obviously ever since I've been off of it. So I don't think that really helped as much, so.
Well, did that at least answer your question?
Yes, I know they're intentional tremors, so
yeah,
it's just annoying,
Yeah, and they're a pain. Right. So I do think it would be worth, even if it's trying to figure out and talk with your therapist, like, what's a modified way that I can like put my makeup on? Or like, is there a different type of keyboard out there that I'm not even aware of? Because like that's too what we as PTs and OTs, right? Like we know all the different types of new adaptive equipment. We know different ways that they've trialed throughout the years. So I would suggest like that would be worth it if that's something really important to you.
Right. I'll say
Yeah.
I'm not in therapy anymore. So
Yeah. So,
I'm
but if it's,
much further along on my journey. So
that's awesome. But even if it's something like we tell people, right, like we're always there, even if it's 10 years from now and something comes
right.
up there,
Yeah.
you never thought you would be doing it and now you're doing it and it's
Right.
difficult. We want to be able to help you make that not as
Thank
difficult.
you. Thank you. I appreciate that.
You're welcome. So we'll head on to our next topic, talking about different activity-based therapies, and specifically looking at functional electrical stimulation. So the rationale behind FES, I'll say for short, is it combines neuromuscular electrical stimulation with repetitive passive rhythmic movement. So that's a lot of, right, medical hoo-ha, like whatever. So what we're doing is like, I don't know if any of you have ever had like an electrode pad. We'll place it on you and we shock you. Okay. And so when we shock you, we're sending a signal to your muscle, depending on the device, either the muscle or the nerve that supplies the muscle, to teach it to fire when it's supposed to, and like retrain that muscle that's been damaged to learn how to fire again and learn that I'm supposed to contract the top of my leg when I want to stand up, because that's the muscle that does it. Or I'm, my bicep. There's different ways that we can do it. And so with functional electrical stimulation, there's different types of devices that allow us to do this in a repetitive way, because as we know, the brain needs a lot of repetitions to learn and to retrain it. I apologize for my dog. To retrain the brain to how to send that signal when it's supposed to, and for that muscle to truly learn and truly make changes on how to perform it. Okay. So in these pictures on the left, we have what's called an FES bike. So you can use that for either the legs or the arms. And so with the legs, like we're talking about tonight for spasticity management, if you have really bad spasticity, we're taking you through this continuous cycle. And the goal is that you could do it 30, 45 minutes for a session. And I've seen patients where like afterward, their legs, I don't like their legs are so tired, and they usually are like, I feel like Jello, right? And so that's where, like Brooke said at the beginning, under the spasticity is a lot of weakness usually, because it's hiding and you haven't been able to strengthen those muscles in the way that we want to strengthen them. So our goal is, can we maybe do a lot of repetition, control that spasticity, and then strengthen, which also is what the FES cycle is good for, right? You can strengthen, we can add resistance, we can try to make you go faster, see how can we go farther within a session. The FES cycle also shows us if I'm using my right limb more than my left, or am I using them 50-50. So that's one option that we have in our clinic, and that we also have worked with different insurances on getting patients to have for home use for lifelong management. We also have what's called the BioNess unit. So we have an ankle, a thigh, and even a forearm cuff. So you can use it for the top of the leg, the bottom part of your leg. So the differences on that is if I have trouble picking my foot up and clearing my foot when I'm trying to walk, the lower limb is really good for that, because it stimulates the nerve to fire that muscle to pick my leg up when I'm supposed to. The upper thigh one, if I have trouble keeping my knee locked, right? If I have trouble staying strong and my legs straight, it can help with that. Or it can help bend and fire on the back of my thigh to help me swing my leg through like I need to. It also can go on the forearm to help with some of the fine motor movements, or moving my arm forward and backwards to help with hand dexterity and those types of tasks. So again, the rationale is that it's allowing that arm or leg to move appropriately, like it did, as close to you did, like you used to prior to your injury, during that specific activity. Okay. We also have what's called NMES, so neuromuscular electrical stimulation. So same thing, it's these surface electrodes that we're putting on these different muscles, and it's re-educating the muscle on how to fire and strengthening. So it's the combination of both. It's just a different device. So this device is called an Excite. Unfortunately, it's not available for home use like the other two were, but you can stimulate up to 6 muscles at a time on both sides of the body. So we can do like bilateral, so both my right and left leg, teaching them how to fire together, or doing my trunk, or doing my arm. And so there's different pre-programmed activities in this device, but we can also make our own. But they have, if we need to do strengthening, if my butt muscles are really, really weak and I can't stand up all the way, or if my thigh muscles are really weak, like we can target specifically those muscles by delivering this shock, right? And teaching you, ooh, I need to fire. And what we look on is when we're stimulating, am I getting that type of contraction? Or is my muscle just not responding? We can also work on transfers. We can work on standing activities as well as walking with these types of devices. And we also have locomotor training, or walking on a treadmill. Okay, so the rationale for this specific type of activity-based therapy is repetitive motion, such as walking, is activating specific inputs that activate inhibitory mechanisms specifically in our spinal cord in a repetitive fashion. So again, thinking what our job as therapists is to cue your muscles, like to cue your leg when it's supposed to bend at the right time and when it's supposed to straighten at the right time, like you used to prior to your injury. And we're doing it over and over and over and over again. So you're getting that repetitive stimulation from us where we're cueing you. And we're just getting a lot of repetitions in to help you practice walking and to help get these, you've heard the term neuroplasticity, right? To get these changes in our nervous system that will hopefully help you walk. And so depending on what type of spasticity you have, right, you might use your spasticity to help you stabilize with walking, or we might be able to help break that spasticity to make your walking a little safer.
So at OSU, we're lucky to have a spasticity clinic. It's through PM&R, or Physical Medicine and Rehab. So there's 4 providers currently that provide spasticity specific management. You do need a referral from your doctor to be able to schedule with the clinic. So typically you would get that from your neurologist, but you could also get it from your primary care physician. The number to call and schedule if you do have a referral to something like that is listed there. Dr. Bavishi is one of those providers. But we also have Dr. Claremont, Dr. Grove, and Dr. Pease. So if you're not in the greater Columbus area, that might be something that you want to seek out in your area. You can talk to your main doctor about that, or you could do some searching through the hospital system that you tend to frequent. Some things that they would do are evaluate your spasticity as far as the degree of your tone. And then also they would review medication options with you. A lot of the things that Dr. Bavishi was talking about last week is the type of information that they would provide you. And then you would decide together what the best management strategy would be from a medical standpoint. Physical therapists also provide referrals to that clinic too, through the assistance of your doctor. So you can ask a therapist too. Speaking of PT and OT, at OSU, we have neurologic specific therapists that are trained in assessing and treating spasticity. So if you're seeking PT and OT out in the community where you're at, you would want to ask, do they have neuro PTs or neuro OTs? And do they assess and treat spasticity? To be able to see a neurospecific PT or OT at OSU, you would need a referral from your doctor. And again, that would typically be from your neurologist if you have one, could come from your primary care physician. And then after you have that referral, you could schedule with our clinic. So what you could expect when seeing a PT or an OT for your spasticity is an evaluation similar to the spasticity clinic. Will assess how strong is your spasticity? What is the pattern? Is it the tendency to bend at the limbs or a tendency to extend at the limbs? And then how are you using your spasticity to benefit you, or is it harming your mobility? So we wouldn't want to remove any spasticity that you're using at your advantage, but at the same time, if it's causing discomfort, we could find ways to work around that. So after being evaluated, PTs and OTs would assist you in finding an appropriate management strategy. So we would trial a lot of these different techniques that we've talked about today to see which ones are the most feasible for you to do independently, which ones are you getting the most benefit from, and then which ones are giving you the most bang for your buck as far as what benefits you are receiving. For example, a standing frame is giving you a lot of benefits for your whole body versus dry needling. We can, based on the equipment that we trial or the tools we use in the clinic, we can help you obtain the equipment that you benefit the most from, such as standing frames. And like Caitlin said, you can get some people can get an FES cycle covered based on your response in the clinic, but also those like splints and braces, things that we talked about there. And then going off of that, we'll teach you how to use these strategies on your own, and or teach your caregivers and family members how to help you do these strategies if you can't do them on your own.
So that is all that we have tonight. Any questions? Thank you so much for calling in and participating and asking really good questions thus far. We've loved getting to educate and talk more about this topic.
Brooke, Katyln, thank you so much. This is really a well done presentation. And I appreciate kind of going through not just what things are, but also how you pay for them and, you know, sort of the real barriers that can be there as well. So yes, you're welcome to type questions in the chat. You're welcome to raise your hand, you know, using the raise hand button and ask a question out loud. Let's see if there's anybody that's jumping out there real fast to ask a question.
I just wanted to say thank you for, I know I work also with other brain injury survivors, but I just want to say thank you because that was very informative. So, and I want my shaky hand to go away. So I will say though that the one thing that helped me a lot was weight training. So I lift like 5 times a week and that helped me tremendously. So for anyone
I love
else.
that. Yeah,
So,
we'd love to hear too from other survivors, like what worked for you, because then when we see someone like, for example, that has a trimmer, I can be like, ooh, I talked to a girl that struggled with trimmers and like, this is what worked for her, right? And like, we're the experts from training, but you guys are the experts by experience.
Right.
So
right.
we love the collaboration.
Right. No, weight training is very helpful. So strengthening your muscles to work in various areas where you have tremors, and that's what helped me.
Awesome.
Absolutely. Your body wants to move.
Yeah, for sure. I'm gonna go, but thank you, and I hope you guys have a Merry Christmas if I don't talk to you then.
Thank you.
Yes, you too. Thank you for hopping on tonight.
Yep.
Thanks for
Have a
your
good night.
questions, Erica.
Bye.
Bye.
So Katyln and Brooke, I'm just thinking about Erica's comment about, you know, or just sort of the nature of, you know, what works for her, right? It's anecdotal, but and it's subjective, as we said, you know, because it's a patient report, it's not some data that we have, but that's what we have. You know, how often do you hear these kinds of things where it's, you know, I tried this contextualized activity, or I tried that sport, or I tried this, you know, like what's the range of things that you kind of come across that have helped people? Is it really big? Is it surprising, or is it?
One example, somebody would come to our clinic from a really long distance and their spasticity would get better from the vibration of the car on them, like from them sitting in the seat. And that's like, hey, that's a good thing, you know?
All right.
It's
Yeah.
so many different things.
It's so different. And I think this is another like plug for support groups, right? So like I made the comment, right? Like we're experts by what we've learned in school and what we've learned with extra training, but there's still so much we don't know because just in the medical field, right? Like brain injuries present so differently. And I never see like two of the same things, right? Like I'll see a piece of it here and a piece of it there. So that's where I think if you get plugged into a support group, that's where you can talk to other people and you'll meet someone, right? That's like, I struggled with that for years and I tried this and it actually worked for me. And then it's like, okay, let me try it. And so that's where I think we learn the most too from our patients is like, we try what we know and like what we know is available and what's out there. And then what works for them, if we see a patient with like a similar presentation, it's like, okay, let's try it. Or if patients are talking in the clinic and they see that somebody's struggling with something that they did, I feel like that's even the most empowering thing is to meet another survivor and learn like what worked for you, what didn't work for you, right?
Oh, it's totally true. So again, if you have questions, you're welcome to type them in the chat. You're welcome to raise your hand. I have only 6 questions. I think you actually answered a whole bunch of them. I'll tell you the one thing that I've been taking away from this series this month, right? You know, we learned about hearing, we learned about vision, we learned about balance, and then we came to this one, and I thought, oh my gosh, there is so much going on here in spasticity compared to those other 3. And not that there wasn't much going on there; there was a lot there too. So there's a lot of different types of spasticity issues. There's a lot of different types of symptoms. As we just talked about, there's a lot of different ways that you can, try to heal and improve. Are there guides or resources to help me or someone else, remember what to look out for? Because I know Dr. Vivici said last week, observing and catching things early was really important. What could we use to sort of be a helpful guide in observing and trying to catch those things?
I would say a lot of times we as clinicians are looking, right? Like right after your brain injury, I know once you're in rehab, that's something that we're constantly trying to assess. But say it's been 5 years, right? And you just start noticing like, man, like I'm really trying to like reach for this cup and I like can't move my shoulder as easily as I could. And so like, or when I'm trying to put my shirt on or I'm trying to pull my pants up, like tasks that have always been easy start to not be easy. That's usually like a good sign that something's changing and we need to look into it, right? Is it now that like my muscles are getting tighter? Or if you start to notice, right, I go to pick up a cup and my hand's shaking. Why? Right? That's not something so I think looking at something new is happening because like we said, spasticity can show up at any time. And we don't know why. Like a lot of times it's initially right after the injury, but sometimes it doesn't show up. Like say you just start to get a lot of function a year or 2 after. With function, sometimes comes spasticity. And so I think if we start to notice these changes where you're not able to do things like you used to, or it's just weird, right? Always reach out. Like we would rather, I'm like, you will never bother us, right? We would much rather catch it early or it truly be nothing. And we give you the peace of mind that it's nothing versus you hold off for 6 months and then it becomes a problem. Like if we catch it early, we might be able to do med management. You might not even need med management because we might try some things in the clinic and make it better. Right. So that's where anytime something out of the norm pops up, I would say reach out to your provider, your old therapist, whoever. We would much rather it be an earlier than later situation.
I kind of want to tag on to what Katyln was saying. I've personally had patients who come in and they're on a lot of different, like a high dose of baclofen or some other type of spasticity medication. And when we trial some of these types of equipment, they can reduce the amount of medication they're taking, which is great because like Dr. Vivici was saying last week, some of these can have a sedating effect. So if you can reduce your risk of side effects or medication interactions and just take less medication through being more active, that's a win-win. So
yeah.
I just want to mention, I put a link to a spasticity fact sheet. These are made for brain injury survivors with patient-friendly language. So you could click that link or save it and bookmark it for, has a lot of this information. And back to what Kadar was saying, as far as, how do I know it's spasticity and at what point would I want to do something? It answers a lot of those questions.
Awesome. Yeah, the fact sheet and really that whole website, is a fantastic resource for you. There's a lot, and sometimes it kind of is helpful to have someone help guide you through that, just because they have so much good information. But it's also good to recommend to your primary care provider, or someone else who's helping manage your recovery,
Right.
because there's just a lot of information out there.
Yeah. And I would say if you're reaching out, like, be very specific, like, because sometimes I feel like we'll have patients come to us and they start to tell us things that they're experiencing. And when we say, oh, have you brought that up to your provider? They're like, oh, no, I didn't think about it. Right. Because sometimes your provider might not think to ask because they have a whole list of other things that they're trying to look at in a short time that they're spending with you. So like, take notes down when you notice things and like either write a date or notice if it starts to get worse. So you can then take that to your provider. And if you have trouble remembering that, like you have this list to say, hey, this is what I've been noticing over the last month. What do you think it could be? Right. And just have that open conversation with whoever.
Very good. So Shannon has a question.
I didn't know anything about this before this video. Actually, this is my first NeuroNight too.
Welcome.
Welcome.
Yeah, welcome.
Thanks. I've been meaning to get on here and I always forget. So yeah. But I think I experienced this actually quite a lot, from what I understand. The first brain injury I talk about, I actually had one when I was a little kid, but my first brain injury was in 2017. I was in a car accident. I got a TBI, and then I actually got an anoxic brain injury on New Year's Day, 21. I was assaulted and strangled. So I'm experienced two different types of brain injuries. But so I'm just trying to figure out, I've been told like different things from different doctors, and I don't know if it's, I don't even, how do you say the word?
Spasticity. That's okay.
Yeah, that. I don't know if that's what I'm experiencing or not. Because I get things like my hand will like cramp up even like randomly. And this has been happening since 2017. And then like my legs will like randomly lock into like a position and all different things. And yeah, like I said, I have tremors in my hands and my feet and all different things. And even I just started going to a new OT today for stuff. And my hands lock up, like I said, a lot, and they lock up in positions. And she pointed out that the tendons on my hands and feet are very pronounced. And she's like, it's not a neuro, they're not a neuro OT, but she was like, wow, your tendons on your hands are very pronounced. Or do your hands like hurt, or do your hands stay in a certain position a lot? And I'm like, oh yeah, that's because my hands like get stuck in positions. So I don't know if that's something part of it, or not. I don't know if that's, I don't know. I have no
So,
idea.
well, and that's another thing too, like even some of these interventions that we've talked about, if you've never tried it, like I've had patients come in like that see Dr. Bavishi and they're getting new recovery or their spasticity actually getting worse. And so Dr. Bavishi will put in a referral for therapy to trial interventions that they like have never tried before. So that's something else that you could look into. Like if you have never heard of this, never looked at it, I would say definitely try to get a referral, which it sounds like you're in OT, but if you could even, I mean, share this slideshow with her or even go over these fact sheets with her. And then see, like, do you think that this could be what I'm experiencing? And like, do you have the means, you know, to help me, or do you know of someone that can? That's another great thing. Like, even if she has never treated this or she doesn't know about it, she can reach out. Like, that's the great thing about the technology world we live in today.
Yeah.
And so I think that, what area do you live in by chance?
Cincinnati.
So I definitely know that there's neuro in Cincy. And that's something too that we, like Brooke and myself I don't want to speak for Brooke. I'm fine with putting my email in. If you guys have follow-up questions like that, to ask us, and we could even try to help if it's like direct you with a neuro PT that we know to reach out or something like that. We are more than happy to do so. But I definitely think if you've never heard of this stuff or tried it and you're like, I think I might benefit, an evaluation won't hurt anyone.
Yeah, that'd be great if you could do that.
Yeah. Is there a way, Kadar, that we could put it in the chat, or is there like a
yeah, so we could put it in the chat. We'll put you know, as long as you're comfortable with it, you know, we'll put it in the follow-up email. So there's a couple things, you know, just first off, we know people across the state. I mean, you know, it's a pretty tight network of people that are working in the brain injury side of things. And so, you know, if you're not in the Columbus area, that's okay. And you're looking for a type of provider, you know, we should be able to help you out. And the other side of it is just, you know, we have a Brain Injury Association of Ohio here in, and
yeah, that's how I found out about you guys.
Oh, okay. All right. So I don't need to point you that way then. But that is a good resource, just in the sort of the same ways that Katyln and Brooke were talking about, you know, just understanding what other people are going through and how they solve those problems. It's also a great way to find providers. And so, you know, you can think about it from that perspective too. So we can put these emails up as long as you're comfortable in those emails and rather our follow-up email and also in the chat. Shannon, thank you for a great question.
Yeah, great question.
Okay, so we have 2 minutes. Anybody else have a question? So I have one last question. We made through all 6 of mine, which is fantastic. So so I have 2. I lied. One based on just the answer you just gave, which is, you know, we have all these technologies to connect people. What about it? Is there telemedicine for spasticity? I mean, I can imagine that it would be quite difficult.
I mean, I would say, right, we could teach you stretches. It would be hard. Like, and I think just like neuro in general, like we're very hands-on. Like Brooke said, we would want to assess like how strong is your spasticity? What direction is your spasticity? Watch you and watch you move, watch your spasticity move. We could but it would be very limited, right? Because you couldn't trial a standing frame. You couldn't trial like functional E-stim. Like there's a lot of barriers to it, but like everything else, it's evolving. I think telemedicine in neuro rehab is actually, I have a good friend in Florida that's on like a task force for it. So I think that we're like our, like our APTA, like as PTs, we're trying to figure out how can we better serve our population, right? In this new telemedicine world. Right now, I think it'd be hard. In the future, who knows? Maybe get a Bioness at your door and we teach you how to do it.
Very good. And then I just want to kind of go into, you know, you talked a lot about the different devices or products that are out there. And they all seem a little bit specialized, right? They seem like, you know, proper medical equipment. And so I'm curious to know, are those the things that you use in the clinic, and there maybe are analogs that you can use at home? And also for people who are trying to get these devices to be able to use in their, daily lives, how often do you see these things get covered? Like, is it at the severe end? Is it most people? Just how does that play out?
It's really
yeah,
device
go ahead.
specific. So
Okay.
I don't do as much of the home access, like electrical stimulation type stuff as Katyln does, so she could speak on that. But like splints, bracing, casting, all of those options, I would say I've never had a problem getting it covered. Most of the time that's already built into your insurance plan. If you look at orthotics or DME, which is durable medical equipment, it'll almost always cover at least a good portion of the smaller items like that. What do you think about standing frames and E-stim?
I would say the typical answer, it depends. So some insurances are great. Some insurances you have to fight, and that's where your medical team comes in, right? Like that's where we as therapists, the representatives of these different companies, we come in, we have letters that support, like, of course, we're not going to recommend this if we don't think it's helpful. So like there's a rationale as to why. So we take objective measures, like how is their strength after? How is their walking if they use this device? How is their balance, right? Like, because our goal is to decrease your risk of further injury, decrease more medical costs, right? So that's where we come in and really show the benefit that you guys need to obtain these devices. Some insurances like Medicare, Medicaid, like they have the waiver where you get a certain like clump of money every year, and these types of devices can go towards that. So a lot of these companies too, if insurance won't cover and like you're having to pay out of pocket, even though it's through waiver, they usually give you a really good deal. So that's an option. We also just now at OSU started a program called NeuroWell, and it's essentially like a wellness program for survivors, like any neurologic diagnoses, like once they're through with therapy. But we also have a component of that where, say the FES spikes works really well for you, but insurance won't cover, or you don't have the means of getting one at home. We have where you can pay a small fee and come in twice a week and do it for management. So that's an option, and we're trying to look to see how we can expand that even more. But that's where, again, as your medical team, we do our best to get it done.
That's awesome. So, if I think about it in this way, you're basically the advocate, right? You're making the case for the patient, or for, even if it's not necessarily your patient from the jump, you're their advocate to making sure that they can get access to these things. So I think that's a great way to think about it. All right. Well, we're a couple minutes over, so I appreciate everybody sticking around. It looks like it's cat o'clock for some of us. And so Brooke, Katyln, fantastic presentation. Again, it was really well done. We will send out the slides again. We'll send out their contact information. Get in contact if you've got questions about how to get care, or some follow-ups from what you heard tonight. And we'll be back next week for the last session of our calendar year, but not certainly the last session for NeuroNights, as we'll be back in January. So come see us next week and have a great rest of your night. Thanks so much.
Right. Bye, guys. Thank you.
Bye.
Bye.